Welcome to our second video on movement disorders. Let's begin. In this lecture, we will discuss tremor and ataxia. We will discuss the definition, classification, clinical features, diagnosis, and management. Tremor is defined as involuntary rhythmic movement involving a part of the body. It is the most common among movement disorders. Tremors can be classified as rest tremors and action tremors. Rest tremors happen when the body part is relaxed. An example of these is the tremor of Parkinson's disease. On the other hand, action tremors appear during voluntary movements. Examples include physiologic tremor, essential tremor, which is typically familial and of autosomal dominant inheritance, and finally, cerebellar tremors, which can be seen in multiple sclerosis and stroke. Let's discuss the clinical features of the different types of tremors. We will begin with the tremor of Parkinson's disease. Its frequency is moderate, approximately 4 to 6 Hz. As we mentioned earlier, it is a rest tremor, so it becomes reduced or absent during voluntary movements. It usually involves the hands and legs and may less commonly involve the head too. Physiologic tremor is an action tremor with high frequency, 12 to 14 Hz. It typically is undetectable in ordinary conditions. However, it can be enhanced by the presence of fever, fatigue, anxiety, or alcohol withdrawal. Medications can also enhance the physiologic tremor. These include sympathomimetics such as amphetamines and terbutaline, theophylline, selective serotonin reuptake inhibitors, lithium, and valproic acid. Finally, physiologic tremor can be detected in some metabolic disorders such as hyperthyroidism and hypoglycemia. Here is how the physiologic tremor looks like. Notice its high frequency. Moving on to the essential tremor. It is an action tremor that has moderate to high frequency, 6 to 12 Hz. It is usually bilateral, typically affects the hands and arms. However, it may affect the head solely. This tremor usually increases with goal-directed movements such as handwriting and drinking from glass, as well as outstretched arms. But it can be relieved by alcohol intake. So when we notice the question stem that the patient is complaining of a tremor, and the tremor improves when he drinks a glass of wine, it is important to keep the essential tremor in our minds. Here's how the essential tremor looks like. It is of a bit less frequency than the physiologic tremor. Finally, let's talk about the cerebellar tremor. This is an action tremor of low frequency, 3 to 4 Hz. It is usually identified as an intention tremor. This means it typically increases when the hand moves toward a target, for example, picking a pen. It is important to note that the cerebellar tremor may be associated with other cerebellar findings such as ataxia and dysmetria. So these additional findings can usually help us define the type of tremor described in the question. Here is how the cerebellar tremor looks like. Please notice how it is most evident when the hand moves toward a target like picking up a pen. Let's move on to the diagnosis of tremors. Actually, the diagnosis is largely dependent on clinical findings, medical history, family history, and physical examination. Laboratory tests can be useful. For example, thyroid function tests to screen for hyperthyroidism and electrolytes such as serum calcium. The main step in the management of tremors is treating the underlying cause and removing the offending factor. However, for the essential tremor, medical therapy should be administered. Beta blockers such as propranolol are the first line. Anticonvulsants such as primidone can also be used. Let's try a question. A 45-year-old woman comes to the physician reporting occasional shaking of both hands. The shaking worsens when she holds a glass or when she's anxious. Shaking improves after drinking a glass of wine. Her father and paternal grandmother had similar symptoms. What is the first-line treatment option for this patient's condition? This patient has a tremor that worsens when she holds a glass or when she's anxious. Tremor improves after drinking a glass of wine. Considering she has positive family history for similar symptoms, this patient likely suffers from essential tremor. The first-line treatment option for essential tremor is propranolol. Let's move on to our next topic, ataxia. We will discuss the definition, classification, clinical features, diagnosis, and management. Ataxia is defined as uncoordinated movements of the body. They may involve the limbs or trunk, and may be unilateral or bilateral. There are two main types of ataxia. The first one is acquired ataxia, which can be seen as a manifestation of stroke, multiple sclerosis, brain tumor, vitamin B12 deficiency, and alcohol intoxication. The second type of ataxia is hereditary ataxia. This can be encountered in Friedreich ataxia, which is of autosomal recessive inheritance, and ataxia telangiectasia, which is of autosomal recessive inheritance too. In our lecture, we're going to mainly discuss Friedreich ataxia and ataxia telangiectasia. So let's begin with the clinical features of Friedreich ataxia. The onset of this disease is typically in adolescence. The patient has neurologic manifestations. These include progressive cerebellar ataxia and cerebellar dysarthria. Remember that dysarthria is a speech disorder that results from motor dysfunction and impaired ability to control the muscles involved in producing the speech. Motor neuropathy, such as weakness and absent deep tendon reflexes, can be detected on physical exam. Moreover, there is loss of proprioception and vibration sense, as well as hearing loss occasionally. Other manifestations that can be seen in Friedreich ataxia include cardiac, metabolic, and skeletal features. Hypertrophic cardiomyopathy is a prominent manifestation and can be complicated by arrhythmia and heart failure. Diabetes mellitus can also develop. As for the skeletal features, kyphoscoliosis, pes cavus, hamartose, and atrophy of intrinsic muscles of hand can all be seen. Before I go any further, I'd like to mention that this image was contributed by Amboss. So thanks to our partnership with Amboss, I can highlight several important features of Friedreich ataxia. So let's look at this patient with Friedreich ataxia. This patient presents with neurologic features that include dysarthria, areflexia, palhypesthesia, ataxic standing and gait, and increased tendency to fall. Palhypesthesia is the reduced vibratory sensation. Our patient also develops hypertrophic cardiomyopathy and diabetes mellitus. Finally, kyphoscoliosis and pes cavus can be detected here too. Kyphoscoliosis is a combination of kyphosis and scoliosis and is characterized by abnormal spine curvature in both the coronal and sagittal planes. Pes cavus means that the foot has high plantar longitudinal arch that is not flattened with weight bearing. Let's look at this image of a patient with deformity of hamartose. Please notice how these toes are flexed or bent, looking like a hammer. Let's next discuss the clinical features of ataxia telangiectasia. The patient presents with progressive cerebellar ataxia as well as oculocutaneous telangiectasias. These are small, dilated blood vessels that appear as red lines on skin or conjunctiva. Abnormal eye movements can be encountered. The most common of these is oculomotor apraxia, which is a defect in controlling purposeful movements of eyes. Ataxia telangiectasia is associated with immune deficiency, so the patient typically complains of recurrent sinopulmonary infections. In fact, pulmonary disease is the main cause of mortality of patients with ataxia telangiectasia. Let's see here how the normal horizontal gaze looks like. The eyes normally move to track and follow the movement of the finger on the examination. However, in oculomotor apraxia, there is impaired ability to perform controlled and purposeful movements of the eyes. Therefore, we see here that the patient has to turn his head to compensate for the defect and follow the movement of the examiner's finger. Again, this defect can be seen in patients with ataxia telangiectasia. Let's see this image of a patient diagnosed with ataxia telangiectasia. Please note the conjunctival telangiectasia, which is a hallmark of the disease. Let's move on to the diagnosis. The diagnosis of Friedreich ataxia is largely based on clinical findings. However, genetic testing is sometimes needed to confirm. Remember from step 1 that Friedreich ataxia is associated with expanded trinucleotide GAA repeats in the FXN gene on chromosome 9. Similarly, clinical findings are highly suggestive in the diagnostic approach of ataxia telangiectasia. Genetic testing may be performed to confirm the diagnosis. We already know from step 1 that ataxia telangiectasia is associated with mutation of the ATM gene on chromosome 11. Let's finally discuss the management. There is no specific therapy for Friedreich ataxia. Similarly, there is no specific treatment for ataxia telangiectasia, and the median age of mortality is 25 years. A 15-year-old boy is brought to the physician for a follow-up visit. He uses the cane to ambulate. The physical exam reveals spastic paralysis of the lower extremities, ataxia and loss of vibration and proprioception over the whole body. He has kyphoscoliosis. His fasting blood glucose was 300 on 2 separate occasions. What is the most likely abnormality on the echocardiography of this patient? The patient has spastic paralysis of lower extremities, likely due to degeneration of the lateral corticospinal tracts. Ataxia is caused by damage to the spinocerebellar tract. Loss of vibration and proprioception can be explained by degeneration of dorsal columns. He has kyphoscoliosis. He also has diabetes mellitus based on his fasting blood glucose levels. All these findings suggest the diagnosis of Friedreich ataxia. The most likely abnormality found on echocardiography of the patient with Friedreich ataxia is hypertrophic cardiomyopathy. And that concludes this section.